Bismillah ar-Rahman ar-Rahim. This lecture 8.1, Membranes and Receptors, Session 8, Pharmacokinetics. Objectives: understand principles of drug formulation and administration, including the use of different sites of administration. Second, be able to discuss oral bioavailability and factors affecting this. Third, define different ways in which drugs may interact. 4, understand the differences between zero and first order kinetics. 5, be able to describe mechanism of drug elimination. First objective: understand the principles of drug formulation and administration, including use of different sites of administration. Pharmacokinetics. What is meant by pharmacokinetics? Simply, it is meant that what the body does to a drug. It refers to the absorption, distribution, metabolism, and excretion of a drug in a living organism. Pharmacodynamics: what the drug does to the body. It is the study of biochemical and physical effects of drugs and mechanisms of actions of drugs in living organism. 4 questions should be asked when we are discussing the topic of drugs and pharmacokinetic and pharmacodynamic processes. First is the drug getting into the patient? So that this means the pharmaceutical process. Pharmaceutical process, how the drug is formulated, whether tablet or injection or so on. Secondly, is the drug getting to the site of action? That is to say, the pharmacokinetic process. Third, is the drug producing the desired pharmacological effect? That is to say, pharmacodynamic process. And lastly, is the pharmacological effect translated into a therapeutic effect? So the therapeutic process. This figure shows these 4 processes: the pharmaceutical process, the drug either oral, given orally or parenterally, other than oral route, for example by intravenous, intramuscular injection, and here the pharmacokinetic process, which involve the passage of a drug from the site of administration, whether from the gut, for example, in oral, from oral route, which be then transported to the liver and to the all other sites of the body, that is to say, into the extracellular fluid. And from here, from the plasma, it will be distributed to other tissues, whether it is bound, some of it is bound to protein, or may be free drug. And the simultaneous metabolism and excretion of a drug, that is to say, elimination of a drug outside the body. These processes involved in pharmacokinetic process. And when the drug reaches the site of action to the tissues, how it exerts the pharmacological effect? By pharmacodynamic processes, that is to say, mechanisms of actions. And lastly, the pharmacological effects lead to the therapeutic effect, that is to say, therapeutic process. Formulation of drugs. First, either solid or liquid. Solid, for example, tablets, capsules, etc., and others. And the rate of action depends on the dissolution of the tablet or the formulation of the tablet, for example, within the GI tract, and this will affect the plasma concentration of a drug. The second, sorry, here one, it is two. Liquid, for example, syrup, suspension, which are taken orally, ampoule or solutions for injections, and other forms. The patient compliance is important here. For example, a once daily dose is easier than taking the drug by multiple doses per day. The site or the route of administration. The site or the route of administration, either local or systemic. The local routes of administration, for example, from the eye drop, skin, for example, skin cream, inhalation, and others. Ear drop, for example, nasal drops, and so on. Systemic, either enteral, which is related to the GI tract, or parenteral. These are the routes of administration. Enteral routes of administration, which are related to the GI tract: sublingual, oral, and rectal. Parenteral, that is to say, other than the GI tract, for example, subcutaneous injection, intramuscular injection, intravenous injection, inhalation, and transdermal injection. This figure summarizes these routes of administrations. For example, topical, enteral, and parenteral. Enteral, which are related to the GI tract, for example, sublingual or buccal, or the drugs which are taken orally, for example, oral capsule. While the parenteral, including the intravenous, intramuscular, subcutaneous injection, or, for example, intravenous infusion. Other sites, we have also other sites of administration, for example, topical, skin cream, for example, rectal, suppository through the rectum, injection all over the body, other sites, special sites, for example, epidural injection. And we have also transdermal patch, a patch on the skin. And we have a topical otic drop or ear drop, ocular drop or eye drops, inhalation also. We have, these are different forms of routes of administration. Objective 2, discuss oral bioavailability and factors affecting this. What is meant by oral bioavailability? It is the proportion of a dose given orally or by any other route other than the intravenous that reaches the systemic circulation in an unchanged form. And bioavailability can be expressed as amount or rate. By the amount, it is measured by the area under the curve of blood drug level versus time. And by the rate, it is measured by peak height and rate of rise of drug level in blood. This figure shows how to calculate the area under the curve, AUC, area under the curve, for an orally taken drug. This is the area under the curve for oral, and this is the area under the curve for injection, AUC, injected. The same drug, if it is given intravenous injection, this is 0 time, this is time, and this is plasma concentration of the drug. When it is injected here, and we took a sample and we measured the plasma concentration of a drug, which is the most important for drug action. We found that the plasma concentration peak at 0 time and then gradually decrease over time to reach or approach 0. While for the oral, for example by a capsule, it increased gradually to a peak and then decrease to approach 0. So that the bioavailability for oral route here, it equals the area under the curve for the oral over the area under the curve for the injected multiplied by 100. Therapeutic window and therapeutic index. Therapeutic window, it is an intermediate range in which effective action is obtained. And therapeutic index, it is the ratio of the dose that produces toxicity to the dose that produces a clinically desired or effective response in a population of individuals. The therapeutic index equals the TD50 over ED50. What is meant by TD50? The TD50, it is the drug dose that produces a toxic effect in half of the population. That is to say, toxic dose 50. Toxic dose 50, TD50. While the ED50, it is the effective dose 50, the drug dose that produce a therapeutic or desired response in half of the population. The therapeutic index is a measure of a drug's safety because a larger value indicates a wide margin between doses that are effective and doses that are toxic. It is a ratio as you see here, the therapeutic index, TD50 over ED50. What is the first pass effect? Substances absorbed from the lumen of the ileum, from the GI tract, they enter the venous blood, which drains into the hepatic portal vein and is transported directly to the liver. This is the portal system. And here, this figure shows that when we take the drug by oral route, for example, a capsule or tablet or liquid like suspension or syrup, when it is absorbed from the GI tract, the venous return almost all the GI tract, except the lower part of the rectum. It drains from the stomach to the lower part of the rectum. They drain directly to the liver. And this is the first pass metabolism. And while the patient is injected intravenously, it will goes to the venous side of or the right side of the body, the right side of the heart, sorry, and then it will circulate to the rest of the body, and part of it comes again into the liver and for metabolism and so on. So many drugs taken orally, they are taken by a high dose because many of or a lot of the drug will be metabolized by what is called the first pass through the liver. So it is called first pass metabolism or first pass effect. Okay. So substances absorbed from the lumen of the ileum enters the venous blood, which drains into the hepatic portal vein and transported directly to the liver. This figure shows or summarizes the first or clarify the first pass effect. This is again from the drainage from the GI tract, from the stomach downward up to the upper part of the rectum. They drain directly to the liver, and here we see many of the drug is metabolized or affected by the liver, and the rest is drained to the systemic circulation. So this is the first pass effect. While on the other hand, the other routes, for example, intramuscular injection, drains directly to the systemic circulation to the heart. Subcutaneous injection also, intravenous injection or intravenous infusion by intravenous fluid, also directly to the heart. We have also sublingual tablet, which when the tablet is put under the tongue or between the teeth and cheek, which is called buccal root. This will make the drug dissociate within the oral cavity and absorb directly to the systemic circulation without swallowing. We told the patient not to swallow, just put the tablet underneath your tongue so that it will be absorbed directly to the systemic circulation, and then from the heart it circulates all over the body. The liver is the main site of drug metabolism, as it contains all of the necessary enzyme systems. So any drug absorbed from the ileum may be extensively metabolized during this first pass through the liver, which is called the first pass effect, as we said. The parenteral, sublingual, or rectal routes can avoid it, can avoid the first pass effect. Again, to this figure, if we insert a suppository through the rectum here, part of the drug which is dissolute within the rectum drained to the portal system, and part of it is drained through the systemic circulation directly to the heart. So the part which is drained through the systemic circulation will bypass the first pass effect. For example, 90% of an oral dose of paracetamol is usually metabolized by the first pass effect. For that reason, we give the patient a dose that is much more than the dose required for intramuscular injection. The third objective, define different ways in which drugs may interact. Drug distribution means the distribution of a drug from the plasma to the tissues, to other tissues, through the fluids of the body, whether extracellular or intracellular. So the therapeutic volume into which a drug has distributed, assuming that this occurring instantaneously. And it is this volume is calculated as the amount given on the plasma concentration at time 0. Plasma proteins, many drugs bind to plasma proteins, and it is the free level of a drug that exerts an effect, while the bound drug does not. It is not the total amount of a drug. Protein binding actions can also occur, and this is important if the drug is highly bound to albumin, for example, more than 90% bound. The drug has a small volume of distribution. The drug has a low therapeutic index. For example, warfarin or tolbutamide, they are bind to proteins, to plasma proteins. Protein binding interactions. We have two types or two classes of drugs in regard to protein binding. Class 1 drugs and class 2. Class 1 drugs, the object drug, they are used at a dose that is much lower than the number of albumin binding sites. Let us see the figure. This figure shows the albumin molecules in yellow and the drug in red. So this is class 1 drugs. The dose is less than the available binding sites. The effective dose of the drug given to the patient is less than the available binding sites. So there is more sites which are free of albumin. While class 2 drugs, precipitant drug, is used at a dose that is greater than the number of the available binding sites. This is class 2 drugs. The dose is greater than the available binding sites. The most albumin molecules contain a bound drug, and the concentration of free drug is significant. When drugs are administered simultaneously from class 1 and class 2 together, class 1 drugs are displaced by class 2, raising the free levels of the object drug and therefore higher risk of toxicity. Here, part C, when both of the drugs of class 1 and class 2 are administered together. If we assume that these 4 molecules of class 1 drug and the action is for the free drug molecule only, when this drug is administered together to class 2 drug, there will be a shift or displacement of these 3 molecules of class 1 drug from their binding site by the class 2 drug, here in green. So we have here 4 molecules, red molecules of class 1 are free now. And if we know that the pharmacological effect or action is related to the free drug, not the bound drug, we assume here that the pharmacological effect will be 4 times more than the original effect if both drugs are administered together. Some examples of object drug and precipitant drugs, and this is important drug interaction between 2 different types of drugs. For example, warfarin, the object drug, and the precipitant drug, sulfonamides, aspirin, phenytoin. When both are administered, for example, warfarin, which is anticoagulant, and the patient is administered or taken sulfonamide antibiotic, this will shift warfarin from its binding site to be more free proportion into the circulation so that its action is increased, and increase the anticoagulant effect leading to bleeding. Tolbutamide also may interact with sulfonamides and aspirin. Phenytoin, the anticonvulsant phenytoin, may interact with valproate, which is also another anticonvulsant. Objective 4, understand the differences between zero and first order kinetics. If drugs are metabolized by enzymes that obey Michaels-Menten's kinetics, that is to say, the rate of metabolism equals Vmax multiplied by the concentration of the concentration of the drug over the Km, which is the constant, plus the concentration of the drug, the C. First order kinetics. In situations where the drug is used at a concentration that is lower than the Km, so that the value of C here is negligible, and the equation becomes Vmax multiplied by the concentration over the Km. That is to say, this means that the metabolism is a proportional, or the rate of metabolism is a proportional, directly proportional to the drug concentration. Directly proportional to the drug concentration. That is to say, when the concentration of a drug increased, the rate of metabolism increased. This is what's called first order kinetics. And usually most drugs, this figure shows the dose of a drug here, and here the rate of drug metabolism. At initial dose or small doses, when we increase the dose of a drug, the rate of metabolism will be increased. This is first order kinetic, which is most drugs, the plasma drug concentration is less than the Km, and drug elimination is first order. That is to say, proportional to the drug dose. While if we increase the dose, usually we may reach to saturation of enzymes or the eliminating processes, so that the body cannot eliminate or metabolize or excrete the drug so far above higher doses, so that the rate of metabolism reaches maximum and then a plateau. And here at this time, or at this dose, we said that the rate of metabolism or the kinetics are zero order. And we have examples, few examples. For example, aspirin, ethanol, and phenytoin, the doses are very large. Therefore, the plasma drug concentration is much greater than the Km, and the drug metabolism is zero order. That is to say, a constant and independent of the drug dose. So zero order kinetics in a situation where the drug is used at a concentration much greater than the Km, so that the rate of metabolism equals Vmax C multiplied by the concentration over the concentration. The enzyme is saturated, and the rate of decline of plasma drug level is a constant regardless of the concentration, because here the concentration here omitted with this one, so the rate of metabolism equals Vmax only. The half-life of a drug, it is the time required for a drug concentration to change by 50%. And during drug administration, a steady state will be reached within 5 half-lives of that drug. If an immediate effect is necessary, a loading dose is therefore needed. This figure shows or simplifies how a drug when it is introduced in the body by infusion. For example, here, this is the time axis, and this is the plasma concentration of drug, percentage of plasma concentration. If we start infusion of drug, the plasma concentration of drug increases like that with over time to reach what's called steady state concentration, at which the entrance or the infusion rate equal to the elimination rate. If we stop the administration here at this another 0 time here, if the drug infusion is stopped, the washout begins by elimination, whether by metabolism, excretion, and within one half-life, this is one half-life from 0 here till here, it is one half-life, we shall lose 50% of the drug. Here the concentration is 100%, this is 100%, and here the drug concentration is 50%. We lose half of the plasma concentration. Over another half-life, this is 2 half-life over time, from 0, this is 1 half-life, this is 2 half-life, the concentration will be 25%. So it is half of the 50. Another half will be obtained at, for example, 12.5%, and so on. They found that at 3.3 half-lives, we shall lose 90% of the drug from the plasma. On the other hand, when we start infusion of a drug over time, at 1 half-life, the concentration will increase gradually until reaching 50% of the 100, 50% of the steady state concentration. When we fix the rate of infusion at another half-life, 2 half-lives, we will get 75% of the steady state concentration. That is to say 50% plus 1/2, which is 25. So it is 75. And over 3.3 half-lives here, we will get 90% of the steady state concentration. At 5 half-lives, we will get the steady state concentration. Comparison between the first order kinetics and zero order kinetics. First order kinetics give predictable therapeutic response from dose increases, and most drugs behave this way, while zero order kinetics give a therapeutic response that can suddenly escalate as elimination mechanisms saturate. Escalate, that's to say increase. Rare examples, for example, alcohol. This figure shows different drug doses over time. This is number of half-lives, and this is plasma concentration, with different schedules of dosing and different dosing. We shall get also a steady state concentration at 5 half-lives. Here the steady state concentration for B schedule of administration. This is for A, this is for C. This is a steady state concentration when the input equals the output. If the half-life is long and a rapid effect is desired, we use what is called a loading dose, and this is often determined by the volume of distribution also. For example, a loading dose, for example digoxin, which is used in the treatment of emergency treatment of atrial fibrillation, or for example heparin in anticoagulation, for anticoagulation. Here we are giving loading dose, a high dose to increase the plasma concentration. This is the plasma concentration to reach the therapeutic level, and then we maintain this level, plasma level, with maintenance doses, smaller maintenance doses, to get the therapeutic level rapidly in emergency conditions. Fifth objective, describe the mechanisms of drug elimination. Drugs are eliminated from the body by first metabolism, and mostly, for example, by the liver, and secondly by excretion, for example, by the kidney. The metabolism of drugs by the liver, we have two phases of metabolism. Phase 1, most drug molecules are stable and relatively unreactive, which are called a prodrug. So in phase 1, a reactive group is exposed on the parent molecule or added to the molecule for the drug molecule to be an active drug. And this generates a reactive intermediate that can be conjugated in phase 2 with a water-soluble molecule to form a water-soluble complex. So phase 2 conjugation process. The most common chemical reactions in phase 1 are oxidation, reduction, and hydrolysis. And the process requires a complex enzyme system called the cytochrome P450, abbreviated by CYP, cytochrome P450 system, and a high energy cofactor, NADPH. Enzymes are inducible and inhibitable, so can be induced by other drugs, for example, or substances, and can be inhibited, and this will affect the metabolism of drugs. Some drugs already have a reactive group on their molecule, so they can bypass first phase 1. For example, morphine is a good example of this. We have enzyme inducers and enzyme inhibitors. Here, this table simplifies some of the enzyme inducers with the drug affected. The enzyme inducer here, for example, phenobarbital, affect the metabolism, and it induced the metabolism of warfarin and phenytoin, so that the concentration of those agents, they are metabolized. The concentration, the plasma concentration, will be decreased rapidly, more rapid than when they are given alone, so that their effect will be decreased. Rifampin or rifampicin, which is an antibiotic, may affect or may decrease the plasma level of oral contraceptives. Cigarette smoking may affect theophylline, which is an anticonvulsant agent. Example on enzyme inhibitors, for example, we have cimetidine, which affect the warfarin and diazepam level. Here, the cimetidine is used for different purposes. One of the most important purposes, it is H2 receptor antagonist used in the treatment of peptic ulcer. It is an enzyme inhibitor. It inhibits the enzymes which degrade or metabolize warfarin and diazepam, so that the metabolism of these drugs will be delayed or inhibited, That is to say, their plasma concentration will be increased, and this will lead to prolonged half-life and prolonged pharmacological effect. Warfarin is the anticoagulant. Increased effect will lead to bleeding. Diazepam, which is anxiolytic sedative, will lead to more sedation. Phase 2 reactions. The reactive intermediate from phase 1 is conjugated with a polar molecule to form a water-soluble complex, and the process is also known as conjugation. Glucuronic acid is the most common conjugate, as it is an available byproduct of cell metabolism. Drugs can also be conjugated with sulfate ions and glutathione. Phase 2 metabolisms requires specific enzymes and a high energy cofactor, which is, for example, uridine diphosphate glucuronic acid, UDPGA. The excretion of drugs by the kidney, only the free, which is unbound drugs, is filtered through the glomerular tuft, through the glomerular filtrate. Drugs can be actively secreted by the tubules, for example, penicillin. This is the second process within the kidney, the excretion of drugs through the kidney. First process is the glomerular, with the glomerular filtrate. The drugs should be free, unbound. And here some of the drugs, for example, penicillin, actively secreted. Some, very minimum amount of drugs are secreted here. Most of them are drained freely with the glomerular filtrate. Here we have tubular reabsorption, and the urine of pH can determine how much of the drug is excreted. For example, for weak acids, for example, aspirin, making the urine alkaline will make the drug ionized. So there will be less tubular absorption because the charged drugs stay in the tubule lumen. These figures simplify this process. Renal excretion of drugs. This is the urine, this is the luminal site, and this is the cell membrane of the first cell of the distal or the renal tubule, and this is a membrane which is phospholipid bilayer. Only fat soluble, which is uncharged molecules of the drug, can pass or diffuse readily through this lipid bilayer, while the charged part of the drug cannot pass, or they cannot be diffused through the cell membrane. Here the weak acidic drugs are represented as HA, and it is a weak acid. It is dissociated into H plus and A negatively charged. When it is uncharged, it is lipid soluble and can pass freely into the body compartments, into the plasma or interstitial fluid, and here again can dissociate according to the pH of the urine. If we increase the urine acidity, that is to say acidic urine, here the availability of the hydrogen ions or the proton will be increased in acidic media. So there will be a shift toward the HA, which is uncharged. So most of the drug will be fat soluble and absorbed through the lipid membrane, readily absorbed through the lipid membrane. While on the other hand, if the urine becomes alkaline, for example by drugs, sodium bicarbonate for example, this will lead to decreased absorption or reabsorption of a drug from the lumen of the tubule to the body compartment. On the other hand, for weak base is the reverse. The weak base are denoted as B and can gain the proton which is H plus to become BH plus, which is a protonated form of the drug. This is the nanoprotonated form of a drug, the B. The nanoprotonated form of a drug of the basic drugs, which is uncharged, which is also fat soluble, can pass readily through the cell membrane back into the body compartments. So when we acidify the urine, we will decrease the absorption, and when we alkalinize the urine, we shall increase the absorption. So for weak bases, for example, amphetamine, this is a drug which is a weak base. The opposite is true, and acidic urine will increase the excretion. Acid urine will ionize a weak base, making the charged drug stay in the tubular lumen. Thank you very much for your listening. I hope it was of your benefit.